Centre for Cultural Diversity and Ageing is funded by the Department of Health under the Partners in Culturally Appropriate Care program and is supported by Brijnath. The series of webinars that we are running is designed to contribute to our vision that all aged care consumers experience inclusive and accessible care along the full spectrum of aged care services. The themes we've chosen for these webinars are in response to a survey we conducted earlier this year of aged care providers across Australia. And so today our focus is on dementia care and exploring some of the issues of examples of good practice in how we support people living with dementia from a diverse range of cultures and backgrounds, and indeed how we can apply a diversity lens to all our work in dementia. I'd like to introduce our first speaker for this afternoon. Nina Catalano works with Dementia Australia. She's a dementia care navigator with a cultural and linguistically diverse focus in Western Sydney. Nina has worked in the dementia field for over 30 years and has extensive knowledge in community care and support, as well as community care and carer education. Today, she'll be sharing with us some of the things she's learnt from her many years of work with clients and carers from diverse backgrounds. So welcome, Nina.
Thank you so much, and thank you for inviting me. So the Dementia Care Navigator and Called Specialist, I guess, something I'm very passionate about, and I am Italian, but that doesn't mean that I know everything cultural, and I have worked in the dementia field, but that doesn't mean that I know everything about dementia. So it's important to recognise those things. So the Dementia Care Navigator was funded in Western Sydney, and it was supposed to be, I guess, the Western Sydney Primary Health Network identified that Western Sydney is a very culturally diverse community. We have residents from over 170 countries that speak over 100 languages, 12% mostly newcomers that don't speak English that well. Now, in the census of 2016, it was identified that the average number of people in Western Sydney from overseas was 49.8%, which is a really large percentage considering that in New South Wales, the average is 34.5%. And 54.1% of those residents were non-English speaking and at home. So again, a very large percentage compared to the average for New South Wales, which was 26.5%. So the Primary Health Network attracted funding to run this particular type of support as a cultural specialist in the Western Sydney area, which is quite a large area. We have 4 LGAs in our area, and it covers quite a large, quite a large diversity of people. Now, the Dementia Care Navigator is a really integral part of the health network. It's a position that works very closely with the health services in the area. Most of the work we do is in partnership to make sure that we are supporting the community the best possible way. The Primary Health Network attracted this funding for this current position, but it is not like the CODA trial. It is very different to the CODA trial. And I do provide some case management along the way for the clients. The benefits of this particular position and funded the way it is that my clients don't need to have a MAC referral to be referred to our organisation. I'm not restricted by age, so I can work with people that are younger than 65 right through to the palliative care stages. It is specifically for people from culturally and linguistically diverse communities that English is not their primary language. However, because of the boundaries, because I'm seen as a called specialist, Sometimes people are referred to me who are just on the boundaries. There's flexibility to support these people as well. Now, the position and the benefit to the community is that I am considered a dementia specialist, and over 30 years of working in the dementia field, I see myself as someone that knows about dementia. However, I always tell everyone that the real specialists are the people that are living with the illness, and all the things that I've learnt over the years, even though I have a degree, I'm learning from the community and from the people, because everybody has their own experience in how they are living with dementia. Now, the position runs groups. We facilitate from early stages of living with the disease right through to end stage. I can support anyone with the MAC referral or the NDIS, and each service is tailored to the individual, because each individual's experience will be different depending on the type of dementia and also their supports. Initially, the service was set up so that I could go and visit people face-to-face in the community, run community support groups and sessions in cultural languages, as well as phone support and emails. Over the last 18 months, we've moved to the Zoom platform, which has worked really well as well, and has taught us lots of lessons of how we can actually reach out and support people in this particular forum. Now, the information, because I am centred in Western Sydney, it is all about local services. And all the work that I do is in partnership with the services that are in the area. None of this work could really be done in a silo, because there are so many components that we need to bring together when working with people from culturally and linguistically diverse backgrounds. From Dementia Australia, we have the expertise of the dementia, but the information we share is unbiased support. So we connect the client to what is best for them at the stage that they're at and support them in understanding. We can provide translated resources and have the ability to work with interpreters, which I've done over the last 18 months. And the interpreters, we work with them on a one-on-one basis in group settings. What I like to do when I'm working with an interpreter is to make sure that I spend 10 to 15 minutes before my session or before my home visit with the interpreter, so that we can have a discussion around my expectations for that session and to support the interpreter in understanding the purpose of the either information session or the home assessment. The benefit also for this particular role is that I can support people from any age group. I think the restrictions where someone sits either in the younger onset or over 65s, I don't have any of those boundaries, which is really, really helpful. I can support people even prior to a diagnosis. So a lot of people that will come to me may be concerned about themselves or their memory. And so we have discussions about what a diagnosis looks like, the sorts of things that the doctors and the medical profession will be looking at. And so there is no barrier as in whether the person is diagnosed or not. I can support them with a diagnosis. I can actually support the person if they need a referral. I can make those referrals for them. And then depending on what level they're at, right through to palliative care. The other benefit for my position is that I am not only community focused. So my service can actually go across into the residential aged care setting and support care workers that work in the aged care settings. I can also provide support for families at that time where maybe someone's moving into care and need a little bit of support and guidance. It's really beneficial, I think, when there's that continuum of care where the people have been able to connect at whatever stage they are at to what they need. And what we've discovered in this role is that people will come in and out of the service depending on what they need. Initially, the service was funded because we were trying to jump in before people got to the advanced stages, because people in the community are not presenting or taking up services, which was the initial brief, was that we wanted to get people to accept services and support and to understand systems. However, what we're finding is that people we are still coming into contact with are actually much further down the track and are only reaching the services at critical stages in their life with the disease. So it has become a little bit more complex than initially seeing this service as an early intervention. In an ideal world, what we'd like is for people to present early and provide that support early. But what we've actually discovered in the last 18 months, nearly 2 years, is that people are actually presenting at a critical point. And that makes it really difficult for the health professionals who are dealing with the crisis, but then needing to connect them back to the community for someone that can provide them that ongoing support, which is what I've been able to do in this role. Now, in Western Sydney, these stats were done at the end of last year. So up to 18 months into the program, I have been able to support people across 20 countries and about 13 languages. So I am a court specialist and I do understand, but really you only understand once you really connect with people, once you build that relationship and rapport. And I'm not going to, even in my own community, which is Italian, I'm not a specialist in Italian culture. We all are specialists in our own history. And so it's really important to remember that and to be open to listening and understanding people and their community and what is important to them. Because we may think we know, but unless we talk to people and understand their history, their life, their expectations, we really don't know. Now, just briefly, why it's important. The statistics for people living with dementia are very scary, and I know most of you out there already know these stats. You know what's ahead of us. And it's why it's so important that we actually make our communities dementia friendly, that we get rid of the stigma, that we accept people in the community and provide support. When we think about every 3 seconds, someone in the world is diagnosed with dementia. And when we're looking at stats like 250 people join the population of people living with dementia every day across Australia alone. So it's everybody's business. It's not just for me because I'm passionate about making sure that people live well with the illness, but we all need to be comfortable around people who have memory change and make those people comfortable as well so that they can live well in the community that they are in. Again, just a reflection on, we understand what dementia is. We know it's not just memory. We know that there are, over 100 different ways that people can get dementia. It's so important that we remember that no two people are alike. And this is so significant in the cultural work that we do as well. It's not a normal part of aging. So, 3 in 10 people over the age of 85, we still have 7 in 10 people that are okay. So we have to keep those things in mind. We have to remember that it's not just one type of dementia. It's not just memory change. There's a lot of things that are happening to a person, and everybody will be different. It will affect everybody different. So these are crucial things to keep in mind when we're working in the community, but also it adds an extra component of complexity when there is language and cultural barriers as well. Now, this is a slide that we use when we put the person in the centre of what we do. And I think it relates so well to people from our cultural communities as well. So the person with dementia, these are the key things that make a person who they are. Now, we're looking at neurological changes and impairment. Again, every person will have change in a different way, in a different area, maybe more than one type of dementia, maybe other comorbidities. There's a personality of a person. Depending on who that person is and what that personality is like will impact on how they are. Their health and physical fitness, that is also so crucial at identifying how this person will cope. Can they hear well? Can they see? How fit and well are they? How many times have we in the community come across a carer who is less well, or that the person with dementia is fitter than the person caring for them? Life history, and again, for me in my work, this is where I focus all of my attention, because I need to know what is important to a person. Now, in my work, it is even more crucial that I learn about life history, that I find out what experiences have my cultural community had when I go to see them. You know, how apprehensive are they with authority and formal things, paperwork and things like that. And also the social and psychology behind their care and support. What social networks do we have around us that are important to us? Now, that's not just important for a person with dementia, it's important for all of us. And when we're working in the cultural community, that becomes even a bigger component of what we're looking at. So I'm not a clinician, I'm not a doctor or a nurse, but I do think that these are crucial things that we all have to keep in mind, is that this is what makes us who we are. And very important when we're working with someone with dementia to understand those other parts of their lives. Now, in my work, connection is the most important part, building that trust and that relationship, because we are going into people who often don't understand even the word dementia. So when we're looking at the support that they need, first we have to understand what their understanding around what is happening is. I spend time, often I know that we're all governed by KPIs and outcomes, but if we don't build that trust at that very beginning, it is really hard to actually work with a family and with a person. I never presume that I know anything. If you don't ask, you don't know. And so it's important. I work with a lot of Italian people. I get referrals for Italian people, but I was born in Australia. My experience as an Italian is very different to other people's experience as an Italian. And it's always really important to understand that we have different experiences depending on what's happened in our lives. Building a relationship is the most important part, and that trust. So I get referrals from the healthcare workers who are overwhelmed with their workloads. They, you know, people present in hospital and it's crisis time. Families are really apprehensive. I need to step in there and provide support, but these people are overwhelmed. The staff are overwhelmed. The families are in crisis and overwhelmed. We still need to take time to listen to their stories, to listen to their concerns. People will talk about what they need, and what people think they need may not be something that we can always provide, but it's important to understand where they're coming from and listening to their stories. And an example of that is I met a family where their crisis was that mum gets up through the night 2 or 3 times a night, every night, and dad isn't sleeping well. So once a week the son comes and stays so that mum can sleep. And the son had rung and wanted to know, can we get a worker to come in and sleep so that dad can sleep through the night? Now, we all know the cost involved. We all know that this is something that a lot of service providers don't go out after a particular time. There's a lot of hurdles, but it's about explaining to the family exactly what it looks like. I actually did some research into if they wanted to pay for a service. It is expensive, but it's not for us to say whether they can or can't or should. They need to know what the facts are and then look at their choices. The family may choose to pay a provider that will come and do an overnight stay. It's up to them. So sometimes we have difficulty with finding languages. We have difficulty with finding appropriate care workers that understand dementia. It's complex, but it's about being honest and straightforward with your consumers so that they understand the complexities around it. When I work with families, I will often set them up with a service provider, and you think that things are going okay, but if the family isn't sure, they need to be comfortable enough to come back to me and ask me questions. Sometimes I go as a mediator between what's happening. An example of that is I had a family referred to me, provided support. We made sure we got the care workers in that were the right cultural background to support the family. But the service wasn't running as smoothly as the son wanted for his mum. He had taken mum out of residential care to care for her at home. They were Hindi-speaking people, but there are Hindi-speaking people from different parts of the world. The language of the workers that were going in wasn't exactly the same as the language that mum understood. So it was about the son didn't feel comfortable to talk to the provider about this. So came back to me to ask my advice and ask if I could support with talking to the workers and supporting them. So when you have that foundation of trust and that relationship, it opens the door for people to feel comfortable to approach you. Now, I have a couple of case studies that I want to talk to you about, because this will just give you a little bit more of an understanding of the complexities of the things that we do see and that happen. And I guess one of the key challenges for me was that initially when we started the project, we were looking at early intervention support for families so that they would present and get support when it was crucial for them to get it before crises. Unfortunately, this is not the way it worked. And one of my first referrals was a client who had been accepted for a level 4 package, and it was about to expire for the third time. And the assessor contacted me and said, I don't know what else to do. This family is desperate. I just don't know what to do, but they're going to lose this package. So it took some time for me to build a relationship with the family. I had actually only 3 weeks before the project, the funding was going to expire again. But I went in and I sat with the daughter and I explained what it all meant. A lot of people don't understand that they have to actually access things themselves, that they have to make those phone calls or find a service provider. So it was about explaining what service providers can do. Many families will say, no one will care for my mum or my dad the way I do. It's probably 100% true, but we have to highlight the fact that if they're not around to care, what's going to happen to the person with dementia anyway. So sitting with the daughter, explaining how the services worked, working with service providers that were actually from the same cultural background that could provide the support that could start really quickly was tricky, but we managed to get that service started for this client without the risk of her losing the package altogether. Now, it was also very important to raise the awareness of the service in the area. Now, my connection to the community is through the health workers. It is through the dementia advisors. None of this work can be done by myself. I'm not an expert in everything cultural. I'm not an expert in everything dementia. We work in partnerships to make things happen for our communities. I work really closely to the dementia advisors in our area. There are things that I can do that they don't have the time or capacity to do. There are things that they do that I don't have the capacity or time to do. So it is really a collaboration within the area of supporting one another to make sure that our culturally and linguistically diverse community and people have the right support the way it's needed. We have had challenges. Finding workers that speak the language is really important sometimes. In some of the cultures, the language is one of the hardest things to find care workers that speak the language. But then we need to look at, language, the spoken word is only a small percentage of what works well with people with dementia. So it's really about understanding the person's likes and dislikes and building that relationship and support and making a person feel comfortable. And an example, I went to visit an Arabic family and the daughter was extremely exhausted and overwhelmed and really kept telling me that no one could care for mum. Mum wouldn't let anyone in to look after her. But I sat there for a while and we talked about the type of support that could come in to take some of the pressure off. And it didn't take very long for mum to feel that it was okay for me to be there. Mum was sitting with us. She was laying on the couch. Mum felt so comfortable that she actually wanted me to stay for dinner and was telling her daughter, you need to feed this lady. And I guess for those of us that come from some cultural backgrounds we're feeding people is what we do, especially the Italians, it just showed me that this lady felt comfortable enough, even though she couldn't understand what I was saying. She knew that I was okay and okay enough for me. And I said to the daughter, just like she's accepting me, even though I'm not speaking Arabic, in time, when we teach the care workers properly, they can also gain trust of the person with dementia, even without language. Now, the interesting part of this situation with this family was that just recently they have bounced back. So I worked with them 6 months ago. We got service providers in that were going to start to provide a little bit of support. We did manage to get Arabic-speaking workers so that the daughter felt a little bit more comfortable for mum, especially when you're doing things like personal care. Language is helpful, but just recently this family bounced back. And one of the things that I've learned from this experience was that even though the daughter spoke English really well, and I speak with a lot of people who have heavy accents, and I don't have a problem with understanding them. So I often, when I connect to people, if they have even minimal English, I will go with that first and give them the opportunity to tell me if they would prefer an interpreter. And when I first met this lady, she was quite comfortable speaking to me in English. So, and I was comfortable that she understood what I was saying. However, when mum bounced back into hospital, the daughter did say she would prefer an interpreter. So we never need to presume, we need to be aware that even though someone may speak English really well, they may still want someone that speaks their language when we're having these discussions. And I know if I'm going to go back to visit this family, I will bring an interpreter with me just to make sure that the carer felt comfortable with that. Now, another situation that's happened, and I think COVID's made situations like this even more tricky, is when people are referred to me, they have an idea of what they think they want. And often that idea is based on very minimal understanding of what's going on in the community. Now, I was referred this lovely lady. She lived in the community by herself. She had a daughter that lived in Queensland and 2 sons that lived in New South Wales, one close and one probably about an hour and a half away. The initial conversations that I had with the daughter was that the daughter was trying to find more support services to go into the home because mum was alone, and with COVID, she was becoming even more and more isolated in the community. So we did talk. Some organisations were still providing some connection into the community at that time. So we did talk about the additional type of support that could be provided for this lady. However, as we unpacked the different types of services in the area and what would happen, the daughter started asking me about residential respite. And so I had to, now this daughter was in Queensland, and so a lot of our conversations were either on a Zoom chat or over a phone call or sometimes emails because the daughter was working. So I provided her with a lot of information about residential respite, how it works, what you need to look at, what type of assessment you need to have, because mum didn't have an assessment that actually covered residential care. And the daughter started to think that maybe putting mum into residential care for respite to start off with might be the way to go. So the family had a discussion around that. And then again approached me saying, what if we want to put mum into permanent care? Now, there's a lot of things to consider, and that's where I pull it apart for families. I help them to understand what it takes to move someone into residential care and the sorts of things to consider. So this family, who aren't all living close and aren't all close to mum, needed to figure out amongst themselves where would be the best place for mum to be, how are we going to make this work, and who's going to be the most appropriate family member that can take on this. So in our discussions and looking at the types of assessments, the family decided that mum needed to move to Queensland. Now, moving to Queensland in the middle of last year with COVID the way it was and all the borders locked down was a really tricky situation. And with my support with information and preparing the family for all the pros and cons. It's never going to be straightforward and easy. And I think we need to be transparent when we're talking to families. We don't want to set up unrealistic expectations. So we did talk about the sorts of things to look out for and the sorts of difficulties that you could have along the way. When the assessment was being done, it was done over the phone. Again, really complex. For those of us in the community that do assessments, there's nothing like that face-to-face connection with someone where you can actually see and hear not only the stories but the body language, the environment, all of those things. But this assessment was being done by a regional person over the phone with mum on one end with her son and the daughter in Queensland. So this three-way conversation was happening. But I was able to provide the family with the sorts of things that they needed to ask and the sorts of things to expect from that assessment process. So they were well equipped when that assessment happened and they got all their approvals. Now, the family decided that mum needed to go and live in Queensland because the daughter had more flexibility with her work to be able to go and visit mum. So again, lots of emails and conversations back and forwards around how do we move mum to Queensland. And we talked again about all the pros and cons. So with this particular family, they did a convoy. The daughter came down to Sydney for a week and helped mum pack up. They did a convoy from Sydney to Coffs Harbour where the son and daughter-in-law travelled in a car behind mum and the daughter. Mum had a bird, and I don't know if you can see, but on the balcony there's a bird that she bought from Sydney up to Queensland. When they got to Coffs Harbour, the lady's son-in-law and granddaughter were there to meet them, and they followed the rest of the way so that the daughter was ready in case there were any situations where mum needed a break or she got distressed. There were other family members supporting that convoy to Queensland. The nursing home, these pictures are from the nursing home. So these are all the things that mum was able to bring from home that made her room look like home. And for myself, being Italian, some of these things are very iconic Italian things. So when I first saw this photo, the daughter sent me these photos saying, we had a lot of hiccups along the way, but we were prepared because you highlighted the things that could go wrong. And she said, this is mum in her room. We had a couple of issues when she first moved in, but they care for her so well. She's got all her things around her, her birds there. And so it was lovely. And the daughter was very happy for me to share the photos because it just showed after a very trying, probably 2 or 3 months of discussions, that we did get a really good outcome for this client, but it wasn't what they were expecting when they first contacted me. The other thing that COVID has opened the doors to is family conferences with people who are really busy. So many of the community people that I support are working carers. And so everybody has their own ideas around how to care for mum or dad, but they don't often have time to sit together because they're busy working, have families. Now, this particular family, I was approached by the daughter who explained to me that mum lives with one of her brothers. There's 4 siblings. However, each one of them takes a day to work from home and go and work from mum's house so that the other siblings can go to work. So every day someone takes a day and works from home to be with mum. But they had never had a chance to sit together and talk about any difficulties or what was going on or how they're going to manage or what types of services they could implement. So I was able to organise a Zoom meeting at lunchtime so that the ones that were at work on that particular day could join into the Zoom chat with the sibling that was with mum on the day. And we were able to have an open conversation about what they felt they wanted to do for mum, the sorts of support that was in the community that could help. They were able to actually talk to one another about the difficulties that they have, because each sibling, if you're in a family, and these dynamics happen in every family, a parent will listen to one sibling more than the other, or if something happens in a family, each family member reacts or relates to it in a different way. Now, these siblings had not been able to have conversations around this at all because they're so busy with working and caring for their individual families as well as mum. This Zoom platform actually gave them the opportunity together to discuss and be respectful of why something might be difficult for one family member and not for the other. I sent them out a lot of information around the types of supports that could be implemented and when they were ready, how to do that. And they were okay with that. They didn't need anything else except for a space where they could talk openly about their concerns, what was going on, and obviously taking into consideration the cultural background for the person with dementia as well. So I think in the world that we're living in, Zoom is actually, or the COVID environment has taught us to do things in very different ways that have still been very productive and helpful. I think most of my working carers, I give people the opportunity to call me a little bit later in the day. So if they're working, I say to them, do you want to call me around 5:30 or 6 o'clock? Working from home gives me the flexibility to do that. And I have quite a few of my carers that are working, and text messages and emails often work best for them. Now, this other situation that I'd like to mention, which was probably one of the things that moved me quite emotionally, I think, I get a lot of invitations to do talks. And so initially my talks were face-to-face. I do like presenting to an audience where I can get feedback from their responses in the room. But over the last year and a half, I've done a lot of sessions online. So I do get invitations to talk about dementia, to talk about services, to talk about my role. And a lot of the communities in the Western Sydney area are doing Zoom catch-ups with their clients. So some of them have moved quite easily into this platform. Now, it's really wrong of us to think that older people don't understand technology. A lot of our people from cultural communities are familiar with technology because they communicate to relatives overseas sometimes on these platforms. So what I've learned from this was that each culture has a platform that they prefer. So maybe not everybody's used to Zoom, or maybe not everybody's used to WhatsApp or FaceTime, but if you connect to the right community cultural groups, they will guide you. I have been able to find out information. There's a lot of platforms like the website for the Cultural Centre of Diversity. PCAC has a lot of information. There are a lot of community or cultural platforms where you can actually ask questions, look up information, and get resources. You can connect to the community leaders. You can connect to people to find out what works in their community. And what I noticed when I was invited to this group, I was asked to do a talk about dementia and changes and services. And I like to log in a little bit before the group just to make sure that everything's working. And so I sat quietly while I was watching all the members. There was about 25 people on the Zoom chat, and I could see them all checking in on one another. And I thought that was extremely powerful, the fact that even though they couldn't be in the room together, they were actually making sure that each one of them, as they joined the group, were okay. And not all of them were set up. Like, there were people, you could see that the family was setting up the computers, people on their phones, people on their tablets. So there was a mixture of people that could do it themselves or people that needed support to do it. I did my presentation, and I had some questions from the audience, which is always good if they're asking questions or interested in finding out more. But what really moved me was that at the end of my talk, a lady presented me with a virtual bunch of flowers, which was absolutely gorgeous. And then she pulled up a YouTube video of It's a Small World, and the whole group sang it to me as a thank you for presenting to them. And I thought it was one of the things, I guess it's one of the highlights for me, because it just opened up such a different way of connecting, and the fact that you really can connect even through this platform. And it was very powerful. It was just a beautiful experience. Now, in New South Wales, we have a model which is called link worker model, and it's in partnership with Dementia Australia and cultural communities. So at the moment, we have a relationship or a partnership with the Chinese Association of Support Services, or what we call CAS, in New South Wales. Now, we have the dementia expertise and support and know-how. CAS has the language and the Chinese community they support. So our partnership is we have some funding which we broker a worker from CAS, and they connect to their community to raise the awareness of dementia and support. In this particular community, they have actually started support groups and are actually instigating different types of support for people with dementia with our support. So with the cultural connection that we have, I can support the workers in understanding how we collect data and why we need to collect data. I can support if they have a client that is a little bit more complex and they need support to understand or look at how they can support that family. I give them that support. I can do a home assessment with them. I can guide them if they're not quite sure. And they have the language and the workers that speak the language. At the moment in New South Wales, we have a Chinese link worker and we have a Cambodian link worker. And the same with the Cambodian welfare. We have a worker that is based with the Cambodian welfare, and we provide the dementia support for them and training and anything that they need resource-wise in language or even with setting up groups or collecting data. Now, the complexity, I just have to add, we have had in the past, we had a Croatian link worker and we have had an Assyrian. So over the years, and the program's been going for over 8 years, but over the years we have had other cultural groups that we've supported. The difficulty is the time it takes to work in the cultural space, because it is a little bit more complex in the sense that we need to make sure that the service is culturally appropriate. We need to make sure that the workers are skilled and trained up, and it's overwhelming. So the funding that we have isn't very significant. Each of these communities may have maybe 2 days a week. One of them only has a 1 day a week. It's a lot of work to expect a link worker to do, and there is the risk of burnout or not being able to cope with the amount of work that there is. So it's a great model, and that partnership works really, really well because they have the knowledge of their community and we can support them with understanding the dementia component, but it's overwhelming work in the sense that there's so much work, there's so many people to help, and really not enough of us to do that work. Now, I'm nearly at the end of my talk. These are the details for my service. The service was funded for 2 years, and we are just waiting. We're sort of expecting that maybe it may get extended for another year, and I'm hoping so because I know that the Primary Health Network is sort of really hoping that the position continues, because it does take a little bit of pressure off them knowing that they've got someone to refer to. But on our website, we have a lot of support. The referral pathway, we're still asking people to still refer through to our organisation for support, because we will continue to help at whatever capacity we have. So even if this position does finish, there will be other resources and support that we can provide because we've done so much work in the cultural space over the years. And I think that that's me for now. So there are a lot of resources online. We have videos in languages. We have a lot of material in languages. So please, reach out if there's anything. If anyone out there thinks that they can maybe set something up where maybe they can support their cultural community with a little bit of guidance or help from us, reach out and ask, because I've been approached by so many people. I've been asked to sit on a lot of different working parties to support the community. So if there is someone out there that wants to trial this, we're more than happy to share information about the challenges, obviously, but also about how well it does work once you do set it up and work with your community.
Thanks so much, Nina. It was so generous of you to share all your insights and your examples, your practical examples. So many of the key points that you raise are about really they just show us insight into the need for connection, the need for flexibility in service provision. And it sort of flies in the face of a lot of the myths that sometimes surround this area around, you know, the sort of things we hear about, that community or, you know, those people from that background, they don't really want these services, or they don't, you know, it's not culturally appropriate for them to do this or that. The issue really is quite often that people simply are not aware of what's available.
A lot of the communities that we work with have come to Australia under very difficult circumstances. So there's that whole fear of the unknown. And so that's where we have to be respectful and take that into consideration, because once you build that trust and that relationship, that disappears, that fear disappears when they know that you're not there to challenge them or ask anything else of them, but to support them.
The other thing that really struck me was when you talked about how you can have connection without necessarily sharing language. That quite often we think that there might be a barrier, or even cultural, you know, sharing a cultural understanding. You know, that often, you know, there are so many things that transcend language and cultural connection.
Look, for me, obviously, because I see dementia as my expertise, not culture, but I think if you use the lens of, you know, being open with people with dementia, it's our body language that gets us in. It's how we are with a person, how relaxed we are. If you're not relaxed, the person won't be relaxed. So culture is similar. You know, if you feel comfortable, you know, there are people that are put off by, you know, a particular, you know, culture because they're fearful because they don't know the culture. But you've got to be open. You've got to learn about it. You've got to be open to hearing their stories. And if they see that you're interested, they open up to you. It breaks that barrier down very easily.
And the question that the notion that you put to us that it's not about you don't know unless you ask. You can't presume. If you think you know, then you still need to ask.
100%. Yeah. Look, I'll give you a personal experience, and this is from my life. My dad had dementia, and this is what I do for work. My dad threw all the things that I know out the window. Like everything that I had learnt over the years was very different with my dad. And it's not just because of the emotional connection as a daughter and dad. It was because of the way his brain functioned. It was very different from, you know, and that's because of who he was, his history, his connections to the community and stuff. So, you know, it doesn't matter what you know, you still have to look at it through the eyes of someone else to truly understand.
Absolutely. Thank you so much, Nina. And if you think of any questions, put them in the chat box and we'll discuss them at the end, hopefully. I'd like to now introduce Bianca. Associate Professor Bianca Bridgnar is Divisional Director of Social Gerontology at the National Ageing Research Institute, NARI. She specialises in the field of medical anthropology and public health and has extensive expertise in the areas of cultural diversity, dementia and mental health. And today she's come on board to share some of the work that they've been doing, NARI has been doing on the Moving Pictures project for some time now. So welcome, Bianca, and it's really great to have you here.
Fantastic. Thank you for that lovely introduction, Tanina. I really appreciate it. So thank you, everybody, for the opportunity to present on a project that we've been leading since 2017 called Moving Pictures, which uses film and digital media to increase dementia awareness across Australia's multicultural communities. This is a very large national project that is funded through the Commonwealth Government's Dementia and Aged Care Services Research and Innovation Grants. And it's a collaboration between NARI as well as Curtin University in WA. A project of this kind is really the labor of many, many people's work. And I'm not going to go through this great big entire list I've got here, but suffice to just say, if you were to quickly cast your eyes over the services, for example, that are involved, and that's just a short list, I promise you. It's really many people's labor involved in it. So what is this project, and I guess more pertinently, why did we do it? Many of you will know that from people from a cold background often present much later for a dementia diagnosis than people from an Anglo-Australian background do. And this can be very problematic because we know from the evidence that if you get a timely diagnosis of dementia, we can do a lot more for you in terms of services and support. We can enable people to maintain their independence, live at home longer, do the things they wish to do for a longer time. We can obtain early intervention, whether it's through the form of certain medications which may slow or delay the onset of dementia, or whether it is through pursuing certain psychosocial therapies and interventions. All of these things in turn can lead to better health outcomes, particularly if there's more forward planning and we know what to look for, as well as planning for the future with regards to care planning, advanced care planning, and family support as the disease progresses. So you generally get better results if you get an earlier diagnosis, a timely diagnosis. But we know in many ethnic communities this is not the case. And that quite often symptoms of dementia are interpreted through cultural lenses, where on the one hand, it may be perceived as a very normal part of aging. And in other instances, it can be perceived as a form of madness, that there are diverse illness beliefs around what constitutes some of the dementia symptoms. For example, we've interviewed various communities, certain African communities, symptoms of dementia are perceived as a sign of witchcraft and a curse. In other communities in Asia, for example, in Indian communities, it's often perceived as a sign of having a bad family. And in other instances, we've interviewed families and, dementia is perceived as something that just happens as you get old and it's nothing really to worry about too much. Irrespective of where the belief sits on the continuum, what really ends up being the result is that quite often families will manage for as long as they possibly can until things eventually hit a wall, right? So there's some sort of crisis that will happen within the family, whether it's a medical crisis, whether it's a financial crisis or an emotional issue, something will happen and that will lead to presentation. And so what happens is when you're having a diagnosis occurring at that kind of point of crisis, a whole maelstrom of events are going on around you. It's not just a dementia that you're grappling with, you're dealing with the family in a state of high emotional flux, and that can create a lot of confusion and chaos. Additionally, we know that in a lot of ethnic minority communities, we have a delay in diagnosis also because people don't really know where to go. Sometimes families may think, well, we know something's not quite wrong, we just don't know where to present. And quite often they might present to the family GP, whom we know from the evidence very often will just dismiss it and say, oh, no, it's all right. This is nothing to worry about. This is a normal sign of aging, and will dismiss symptoms. In other instances, families may not know about how the health system actually works, so they're not quite sure where to go for additional support. And of course, language issues are a prevailing and ongoing concern in terms of disadvantage and barriers to seeking help, particularly if the person who has the dementia is losing their language capacity, be it in English or in their mother tongue as the dementia advances. So bottom line is timely diagnosis is really helpful, but it doesn't happen in ethnic communities. Now, this is a problem. I guess I'm telling you what you already know, and I think what Nina's covered really well. But this is important in the Australian context, in large part because we are one of the most multicultural societies in the world. About 30% of our older population comprise people who were born overseas and who speak a language other than English. And this number is foreshadowed to grow into the future, as is the number of people who are living with dementia who come from a non-English speaking background. Now, we are a society that prides ourselves on ensuring health equity for all, and that's very integral to our national identity. And so therefore, if we want to achieve health equity for all, we actually need to work on reducing disparities, and there is an urgent need to inform different CALD families and communities about dementia to avoid delayed diagnosis and facilitate a timely access to care. That's basically the crux of what Moving Pictures aims to do. And we use film and digital media to do this, principally because we recognize that the capacity of people to tell their own stories in an accessible format overcomes barriers of literacy in language and in English, and it forms a much more engaging and empowering way to learn about what happens next and where you can go for help. So that's the aim of Moving Pictures. The methods we use are really around co-design. This is quite a complicated slide, but I'll talk through it to explain what we did. So what we did is we started off by doing video interviews with CALD family carers across Australia. We originally started with funding for 5 different languages. These languages were Mandarin, Cantonese, Arabic, Hindi, and Tamil. And then we got funding to do an additional 4 languages, which was Italian, Greek, Spanish, and Vietnamese. Collectively, these 9 languages reflect the top 10 languages spoken in Australia's established and emerging CALD communities. And I guess we produce these films with a view towards addressing current need, but also trying to anticipate needs in future needs in growing communities. So all up, we did 112 interviews, video recorded interviews with CALD carers around Australia. And we also interviewed health professionals, that is GPs, geriatricians, ethno-specific health workers, people who worked in residential aged care, etc. So the interviews were obviously in the 9 languages and also in English. We had bilingual researchers who we trained to do these interviews, and we also trained them in some aspects of filmmaking to facilitate that process. Although COVID, of course, threw a big spanner in the works. I won't talk about how we did the workarounds there, but if you want, I can elaborate on that in the Q&A. What we did then is once these interviews were done, and each interview sort of went for around 45 minutes, we then transcribed and concurrently translated them verbatim, and then we analyzed them to create storyboards for the films. So we created draft storyboards for the films and then convened steering committees and groups comprised of carers from those languages, as well as providers from those languages. And we then co-produced each storyboard with that committee. And we co-produced 3 films. So there's 3 films that are common across all of these 9 languages. That's films that we look at detection and diagnosis, how to navigate care, and I guess the kind of carer journey or the emotional journey that carers will go on in providing that. And this is with regards to family carers. So I've talked about the languages and the 3 films. And what we've done since then is once we've produced the draft copies of these films, we then actually feed it back to the original interview participants to see if they're happy with what we've done. We also feed it back to the workshop participants who helped us co-produce the films to see if they're happy with what we've done. And then we also feed it back to the respective communities through a survey to see if they're happy with what we've done. And so through these 3 methods of member checking, we kind of finalize a film, make a few changes, and then launch them as they go along and screen them as far and wide as we possibly can to seek to raise awareness. So that's kind of the process we undertake. To date, like I said, we've got those 3 films. They're available on our website. These are all available for free. You can access them, you can use them, you can share them. You don't need any permission from us. What we also did with the films is we converted them into comics as well. So you would have noticed that there is a bit of animation present in some of my PowerPoint, where I'm sharing, you see sort of these cartoon kind of figures and you're thinking, what's that about? That's actually the animations we've created from the films themselves. So the animations are based on evidence and the real life stories of people. And then we put this all on our website. That's roughly what it looks like. So the website is partially catered to people in their own language. And again, everything is available over there for free. We have hard copies of our comics as well, again, which you can order for free. Just let us know how many you want and we'll send them out to you. I thought what I'd do is give you a bit of a taster of a film that we've got in production that's due for release later this year. This is from the Greek community. It's the Kera film.
Να βλέπω τη μάνα μου, ένας γερός άνθρωπος που ήταν το στήριγμά μου, με βοήθησε στις δύσκολες δικές μου στιγμές. Είναι ο ήρωας μου, πώς θα το εξηγήσω. Και τώρα να τη βλέπω έτσι, με πονάει η καρδούλα μου, αλλά τώρα ήρθε η ώρα να σταθώ εγώ σκληρή για τη μάνα μου. Όσο ήταν αυτή σκληρή, θα σταθώ και εγώ σκληρή για τη μανούλα μου.
Νομίζω για τους carers που προσέχουν τις γονείς τους, αυτό που θέλω να πω είναι στη σημερινή ζωή που ζούμε είναι πάρα πολύ δύσκολο γιατί έχουμε τόσα πολλά γύρω μας, παιδιά, άντρες, ο σύζυγός μας, δουλειά και όλα αυτά. Μόνο μπορείς να κάνεις το καλύτερο που μπορείς να κάνεις και
We appreciate that carers don't have a lot of time. People are very busy. So we try and keep to the point as much as we possibly can. So our impact to date since launching in 2019, we've had over almost 20,000 visits to our website. We've got about 620 odd followers on Twitter and about 200 on Facebook. We've distributed over 9,000 comics across the country. We've been featured in a lot of mainstream media, as well as the SBS and ethno-specific media. We're listed as a key resource on the Australian Commission on Quality and Safety in Healthcare and on various state government websites as well. We're also listed in various ethno-specific organizations, including on the Centre for Cultural Diversity's website. And we were championed by the former Minister for Aged Care, the Honourable Ken Wyatt. He's no longer the Minister for Aged Care at the moment. Our work is also widely pushed by the Federation of Ethnic Communities Council of Australia. So we are engaging with a number of different services and people across the country to affect change. And I'd really strongly, I guess my plea to everybody listening today is that if our resources can help you, please just use them. Like I said, they're free. You don't have to ask permission. If you need the comics, hard copies, let me know. I can get them out to you. No problem at all. So just to give you a bit of a taste, I guess, of the uptake and the next steps. Well, you may not be this interested. This is sort of the academic side of it in terms of the papers we're developing and the additional films that we talked about that will be released by September. This might be of interest to some of you as well. So with further funding from the Commonwealth Government, we've also created ADAPT, which is animating dementia prevention in cold communities, because one of the things that we consistently found when we went out around the country to talk to different communities, they'd say, oh, this is great. We like these films on dementia, but can you tell us what dementia is? And then you say, oh, right, okay. You explain it and they say, oh, what? It's a very serious condition. Now, and how do we prevent it? So what we're doing here is using the collateral or the animations from the original comics, where you can expand on that. And we're going to produce a very short animation, again, about 2.5 minutes in 9 different languages on how we can reduce our risk of dementia. And again, this will be available for free and around the country. So we're in the process of just testing out the prototype we've developed through focus groups in Melbourne. And we're hoping to do a national tour, a little roadshow later this year. So if you are interested in us coming out and screening it at your facility or with some of your residents or clients, please get in touch with me. We're really happy to do that. Additionally, we've got funding from the Alzheimer's Association in the USA to replicate a model like this in India, because this kind of approach is very helpful for countries where they don't have a lot of resourcing to allocate towards formalized support services, and where a lot of dementia care may occur at home. And digital media is a really innovative way to get learnings to people's homes and to enable them to access support in their language in a kind of very digestible format any time of the day or night. So that's a bit more funding we've got there, and we're starting that work later on this year, subject to COVID, of course. We finally, what we're also doing is we're creating a little moving pictures genie. This is without any resourcing at all. What we're doing is looking at the resources and that have been created for migrant communities across the world. And we're looking to, collate quality resources, put them on our website in a sort of one-stop shop as a searchable page, and open it up to the world for whoever might want to access them in whatever languages we can find that are of good quality and evidence-based. So that's a bit of work we're also doing. And we've teamed up with people from Europe, the US, India, and other parts, I think Latin America as well. And we've got a few students from Monash Uni also involved, which is great.
Thank you so much, Bianca. It must be so amazing to be involved with such an incredible project. It just sounds ideal, really, the fact that you've been given the sorts of resources that are needed to actually do a project with such depth, and to be able to bring in all the factors that make a project like this work. So the resources look amazing. I hope everyone gets a chance to hop online and use them. We did have one question by someone about whether you're thinking of whether there will be more languages in the future. You may have said that, but someone was asking about Croatian.
So at the moment, sadly, our funding runs out at the end of this year. So we're contracted to deliver 9 languages, which is what we're doing at the moment. We would love to do more. I think there's a whole lot more to do. We would also really love to actually develop much more practical resourcing also now around care. We think there's some really great advice that can be done for carers on how to kind of manage difficult situations because, these difficult situations, they always arise in the middle of the night on a Saturday night when there's no service around. So I think that's when people kind of end up, needing everyone's at their wits' end thinking, now what do I do? So that's what we'd like to do next.
On the Dementia Australia website, we do have, and you can YouTube it as well, It's Not a Disgrace, It's Dementia, and it's in Croatian. So if you go to YouTube and you look up It's Not a Disgrace, It's Dementia, and put in Croatian, because we've got a lot of languages, I think we've got about 11, that's also on YouTube for people to access as well.
The other thing I really love about the project, the Moving Pictures project, is that it's based on that co-design idea, and it's so intrinsically, focused on adapting it to the needs of particular groups. Is this great?
Yeah. So we focus a lot on the co-production and the co-design elements of the project. And look, I will say we don't always get it right. And there are times when we know we haven't got it right and we're just not going to be able to get it fully right. So I didn't talk about some of the complexities of the project, but we've had instances where, for people who've taken part in the project, as I say continuously, this is not your pathway to the Oscars. But, there are a few people who do get upset and are kind of like, well, I gave 60 minutes of my time and I did this great interview and now there's only 30 seconds of me in this film. What happened? And so you kind of have to grapple with that. And we're in the middle of doing surveys with the Italian community at the moment about the Italian films, and we're getting a lot of feedback. So I'm a bit worried. I'm a bit worried.
Us Italians are happy to give feedback.
But I'm looking forward to it.
There was a question actually for Nina as well in the chat. Nina, if you're there, it was about whether or not Dementia Australia is thinking about trying to replicate this type of service that you have in other states as a model.
Look, it's more about attracting the funding to do it, because as you can see, it is quite time consuming. I have over 120 clients on my books. It's only me. So it's one of those things, it needs to be funded properly. We have developed outline for the model so that anyone that wants to try and implement it, we're obviously happy to support with that. But it's all based on funding, as we know. That's why I know how important it is to keep our records. And when I work with my link workers, guiding them to understanding the importance of that, because that's what's going to feed into trying to attract the funds to actually keep doing this work.
Yeah, it's always comes back to the question of funding. All the great projects require funding, and however, I hope that from what you shared with us today, people are able to sort of to grab at least some of that low-hanging fruit that they can translate into their own work, even if they don't have a dedicated person in that role that they can refer to, that type of thing. But yeah.
Look, and more than happy, like if anyone wants to get in contact with me to share support in how to do that, I'm more than happy to help with that as well.
Yeah, fantastic. And we're also always happy at the centre to bring those links together. If anybody has any queries or questions, we're happy to take questions and, take a call and help create those linkages where we know things exist. So, yeah. Look, I really, really appreciate your time today, Bianca and Nina. It's been quite eye-opening, I think, to be able to hear about your work and your stories, and it's an opportunity that we don't often get. So thank you very much. Obviously, we're always encouraging people to check in on our website for all sorts of resources around anything to do with cultural diversity and ageing. We consider it like a national hub of information, and we try and keep it as up to date as possible. So this is something that you might be interested in exploring, the sorts of resources we have on here. For example, why am I not moving? Here I go. For example, the fact that we have a lot of multilingual health and aged care information on the website itself. Like Bianca said, we link the information that she's developed. The project, the Moving Pictures project, is linked, for example, through our website as well. There's a lot of multilingual information. And if anybody knows about information that could be there that isn't there, I'd really appreciate you letting us know, because it's important that just people know what's available to them, and hopefully not also reinventing information that already exists. That's really important. Just wanted to remind people about our inclusive service standards and the portal that we've developed around the inclusive service standards for aged care providers to do their own self-assessment online for developing services across the organisation, which can address issues to do with diversity and inclusion. And we have a whole suite of resources sitting on the portal, but also sitting on our website that can help you work through what it means for an organisation to become more inclusive in its approach. There are things like tip sheets and all sorts of templates that you can download. For example, diversity and inclusion policy, a staff survey, and community feedback forms in 12 different languages, just to give you an example of what sits in our inclusive service standards portal. If anybody wants more information about that, please reach out, and happy to walk you through it. Just a glimpse over the next the topics that we're still to come in our diversity training series. So we're still looking at issues around communication, about inclusive organisations, about including linking inclusive practice to the quality standards, aged care standards, and applying a diversity lens to consumer-centred care, and inclusive consumer feedback. We, as I said at the beginning, we record all our webinars and we put them up on our website in perpetuity, so you can catch up with any of the ones that have gone on in the past as well. Just a quick heads up about our upcoming Cultural Diversity in Ageing conference on Thursday the 17th of June. It's a half-day virtual conference called Care to Communicate, and it really focuses on hearing the voices of older people in the aged care space. So we really invite you to register. It's all for free, and come in and join in on the fun. The other thing that I want to flag is that we have our Cultural Diversity in Ageing Excellence Awards now open for 2021. And if you visit our website, there's still time to the end of June to put in a nomination around either organisational leadership, either service delivery, or for individual excellence. And again, if anybody wants any more information, feel free to throw us an email or give us a call, and happy to talk you through that too. Thank you very much, everyone. Looking at the time, good timing. It was lovely to have you today, and I hope to see you at one of our next webinars. So cheers.